The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Hi everyone, my name is Dr. Shane Fajutagana. You can call me Doc Shane or Ma'am Shane. So I'm a graduate of the PGH residency training in obstetrics and gynecology, and I will be the one to deliver the main lecture of the Genesis OB/GYN part. Okay? So my lecture will be divided into 2 parts, obstetrics and gynecology. My discussion will center on clinical scenarios. So very practical na yung knowledge na i-share ko sa inyo. So a lot of it is based on your Williams and Compre-Gyne, pero mas marami or well, a lot of it are coming from your CPGs or your clinical practice guidelines from our local society, which is POGS. Okay, the Philippine Obstetrical and Gynecological Society. So let's start. Okay, so first of all, we will start with the history taking. Sabi nga nila, di ba, most of your assessment will come from your history taking. So scenario number 1, we have a patient named Maria. You saw her at the OPD, and she came in for prenatal checkup. So una sa lahat, ano yung itatanong nyo sa patient? So unang-una, sasabihin nyo muna, tatanungin nyo sa kanya, ma'am, ilang taon na po kayo? So after that, you don't say the word female, di ba? Usually sa IM, sa ortho, sa general surgery, or in any other subspecialty or specialty, sinasabi nila yan. We have a 19-year-old female, 18-year-old male. Sa OB, understood na you have a female patient. So kapag meron kang OB patient, OB/GYN patient, diretso ka na sa OB score. So when you report to your resident, you tell her, ma'am, we have a 35-year-old, then state the OB score. Maliwanag? So baka pagalitan kayo if you say 19-year-old female. Tanungin ka, may male ba tayong patient sa OB? So don't say that. You go straight to the gravidity parity or the obstetric score of your patient. Okay, so bakit importante yung age? So sa OB kasi guys, kaya importante yung age kasi we usually lump the diseases, the pathological cases according to their age group. So we look at the premenarchal, ito yung mga 7 years old, 8 years old, before sila mag-mens. Iba yung tumatakbo sa utak namin na algorithm kapag premenarchal yung patient. Pag reproductive age, anong ibig sabihin ng reproductive age? So this is the age between the start of menses or your menarche and the age of menopause. So that's your reproductive age. So syempre, after the reproductive age, you have your postmenopausal age. So for each age group, iba-iba yung naiisip namin na sakit. So we obstetrician, gynecologists, we always think in algorithms. And our algorithms always start with the age of the patient. So now we go to the OB score. So si Maria, natanong na natin, she's 35 years old. She has had 2 term pregnancies. Both babies are currently living. 1 ectopic pregnancy. 1 preterm delivery at 8 months. Unfortunately, this baby died at 1-year-old due to pneumonia. And she also mentioned to you, actually, doktora, meron pa akong isang pagbubuntis eh. Nakunan po ako ng isang beses. Okay, so what is now her OB score? So first, you start with the age, as I mentioned. So she's 35 years old. Next, you mentioned the gravidity of the patient, the gravida blank. So ano tong gravidity? So when you say gravidity, this is the total number of pregnancies. So abortion, preterm pregnancies, term pregnancies, lahat yan, nasa gravidity. Next is your parity. So parity are all your pregnancies that were carried beyond the age of viability. Anong ibig sabihin ng age of viability? Beyond this age of gestation, kapag na-deliver yung baby, may chance na mabuhay. Viable yung iyong fetus. Okay? So, ang consensus sa Philippines, usually across all hospitals, we peg this at 20 weeks, okay? So, parity are all pregnancies that go beyond 20 weeks. Next is your FPAL. This could also be called PPAL. So, ito ay extended notation lang ng iyong gravidity, okay? So, when you see F, F stands for full term. Minsan P, term, okay? So, parehas lang yon. So, P is preterm pregnancies. A is abortion. L is living children. Note, living children, not live birth. Okay? So, some notes about your FPAL. So, your FPAL, your full term, kailan mo masasabi na full term yung baby mo? So, full term if na-deliver siya at 37 weeks or beyond. Okay? So, obviously, pag preterm, less than 37 weeks, but more than 20 weeks. Pag abortion naman, less than 20 weeks. So, ang kasama sa abortions mo are your miscarriages, your molar pregnancies. Molar pregnancies are also called H-mole. The Tagalog term, the Filipino term for your H-mole is yawa. So, kapag yung patient mo sinabi sa'yo, Doktora, nagkakyawa po ako for my second pregnancy. So, that is considered an abortion, your molar pregnancy. Next, kasama din sa A mo are your ectopic pregnancy. So, ito si patient, meron siyang one ectopic pregnancy. So, dadagdag yan sa score niya sa A. L is for living children. So, note na ito ay live births. Okay? So, tingnan natin, sagutan muna natin itong OB score nitong patient na to para mas ma-realize nyo kung paano tayo nag-OB scoring. Okay, so what is your OB score? She's a 35-year-old G5. Why G5? 2 term pregnancies, 1 ectopic pregnancy, 1 preterm delivery, and then nakunan po ng isang beses. So probably meron siyang abortion at some point in her life. So that's a total of 5 pregnancies. So P3, why P3? Hindi natin ika-count si ectopic saka yung nakunan siya. We're assuming na itong sa nakunan na to, less than 20 weeks. Okay, so ano yung nasa PPAL niya or FPAL? 2, so this is obvious kasi 2 term pregnancies. 1, kasi meron siyang preterm, 8 months. Okay, so kulang sa buwan. So 2 per your, teka lang, I will use my laser, ayan. So 2, because meron siyang isang ectopic and isang nakunan, and 2, because dalawa lang ang currently living. So hindi mo isusulat na 3 dahil sabihin mo, ay buhay naman tong preterm nung nilabas eh. Hindi siya counted na sa L, okay? L is living children. Malinaw? So far, clear? Okay. Sige. Next. Okay. So what if ganito, palitan natin yung scenario. Si Maria, meron siyang 1 full-term stillbirth. Okay? So kompleto sa buwan, pero namatay sa sinapupunan. Yun ang kwento niya. So how will that change your OB score? So now, she is G6, P4. Why G6? Okay? Bakit nga ba G6? Okay, so teka lang guys. Balikan natin yung previous OB score niya. Okay, note, diba? Tingnan nyo to. Baka hindi nyo napansin. G5, diba? 5. Pero remember, this patient, based lang dito, G5 siya. Pero remember guys, this patient is coming in for prenatal checkup. Therefore, kasama na yung G6. Nakita nyo? Na muntik ko na rin ma-miss out eh. So, if isasama mo itong current pregnancy na to, you will be reporting the patient as, this is a case of a 35-year-old G6, P3, 2122. So, hindi mo i-report yung status ng current pregnancy dun sa parity and the FPAL kasi hindi mo pa alam kung ano yung outcome niya. Pero, ika-count mo siya sa G6, dun sa gravidity, if the patient is currently pregnant. Na-get? Okay. Yan. Na-miss out ko yon pero yan. Buti na lang meron tayong buti na nakita natin dito sa next slide. Now, let's do a change in scenario. Instead of 1 ectopic pregnancy, meron siyang 1 full-term stillbirth. Okay. So, how will that change the FPAL? So, the FPAL will now be for the term 3, for the preterm, 1, kasi meron siyang preterm delivery. For the abortion, 1. Okay, 1 to. And then, for the living children, since dalawa lang yung buhay, yung full term niya na baby, pinanganak ng stillborn, 2 pa rin yung live birth. Okay? Malinaw? Okay, so other basic terminologies in your obstetric scoring. So sometimes instead of mentioning G0, we say nulligravid. So that's the same as gravidity. So obviously, gravidity yung tinitingnan mo dito. Null, meaning wala. So kapag never been pregnant, nulligravid yung patient mo. Primigravid, if this is a G1 patient, P0. Note na hindi ko na ni-note yung tipal. Kasi obviously, kapag ito yung first pregnancy niya, P0, then the rest ng nasa loob ng tipal mo is also 0. Okay? Multigravid is at least G2. Primipara, you look at the P1. Okay? So P1 ang primipara. Multipara, obviously, P2 and above. When you say grand multipara, you look at the parity. It should be at least P5. Okay? So kapag may patient ka na 53-year-old G7, P7, 7007, you report the patient, isasama mo sa diagnosis, grand multipara. Okay? Next, elderly primigravid. So we indicate this for patients who are aged 35 years old and above during their first pregnancy. So in some institutions, like in our institution, we also indicate if the patient is a young primigravid. So meaning during her first pregnancy, she is 18 years old and below. So sabihin nyo, bakit napaka-ages naman ng mga OB? Ba't kailangan i-mention na elderly tas young primigravid? The reason behind this, guys, is because the age will tell you that this patient is predisposed to certain comorbidities. So obviously, kapag elderly ka, nandiyan na lumalabas yung mga lifestyle diseases mo. So these patients are more prone to your hypertensive disorders of pregnancy, to your GDM, etc. Okay? Pag young primigravid, ganun din. Ang isang theory behind it is, first of all, you have a pediatric patient carrying another pediatric patient. So obviously, there will be problems in terms of nutrition for this patient since nagtatalo silang dalawa regarding that. And second, your hormonal milieu as a as a pediatric patient, as an 18-year-old, is not as mature as when you're, say, in your 20s, no? So ang tendency mo nun, you are more predisposed to diseases like preeclampsia, gestational diabetes mellitus, and also because yung habitus nila, most of them are small, yung pelvis nila are not developed, sila yung pina-watch out for namin for dystocia or your dysfunctional labor. Malinaw? So we are ages for reasons, okay? We really look at the age because yan yung mga binabantayan. Diyan kami may mga binabantayan. Malinaw? Okay, so grand multipara, anong binabantayan natin dito? Marami rin kasing comorbid conditions ang mga multiparous patients. So example is atony. So pag mas mataas kasi ang parity mo, as your pregnancy, as the number of your pregnancy increases, less contractile na siya in your next pregnancies, in your subsequent pregnancies. So when that happens, these patients, they become more prone to uterine atony or obstetric hemorrhage. So isa lang yan sa mga examples ng mga reasons why these basic terminologies came about in our practice. Okay? I hope that's clear. Sinasama namin to sa diagnosis, guys. Okay. Okay. So now, di ba, I told you kapag yung current pregnancy, sinasama natin yan sa G1 na. Okay? So, okay. Ito naman, may special endorsement ako dito. If I should say endorsement. O sige. For multifetal pregnancy. So, these are your twin pregnancies, your triplets, your quadruplets, etc. Okay? So, yan yung multifetal pregnancy. She's currently pregnant. So, this is G2. Kasi meron siyang prior pregnancy, which happens to be a prior preterm delivery of twins. Both are living. So, paano mo sinusulat to? Now, guys, this is the tricky part. That is why I'm saying na ito yung special endorsement. Okay? Bakit? Kasi magkaiba ang nasa textbook sa ginagawa ng mga OB or sinusulat ng mga OB in practice. I'll tell you why later on. So this patient, you start with the age, 32-year-old. So ano may susulat mo? So obvious naman tayo sa G2. Okay? And very clear si William, isa lang ang count mo sa twin pregnancies. Clear dyan si William. Counted yan as one. Kasi pregnancies yung binibilang mo dito, not the deliveries. Okay? Okay, sa TPAL, dun tayo nagkakaiba. Sabi ni Blueprints, si Blueprints lang ang clear about this sa textbook. Williams, wala siyang sinabi about this, but your Blueprints OB-GYN, which is, by the way, the main source of the Board of Medicine for your board exam. So if you want to read ahead, you read your Blueprints. Anong sabi ni Blueprints? How would Blueprints write this? Okay. So triplex theme lang din. So it doesn't matter kung ilang order, kung higher order pregnancy pa to, P1 pa rin yan. Okay, balik tayo sa twins kasi complicated enough na yung twins. Okay, so sa Blueprints would write it as 0, 1 preterm delivery kasi, 0, 2 living preterm babies. Okay? Okay, so yan yung sa Blueprint. So just to show you, this is the source. Okay, so may binigay siyang example. For example, a woman who has given birth to one set of preterm twins, one term infant, and had 2 miscarriages would be, anong OB score niya? Ganito na sinusulat yung OB score. G4, 4 because one set of preterm twins, one term infant, 2 miscarriages, so 4. Okay, P1, 1, 2, 3. Okay, C1 is a C-term infant. C1 is preterm twins. Ito, pinount niya lang yan as 1. Yung 2 abortions na ito, 2 miscarriages, and 3. Sa 3 pa lang magre-reflect yung number ng babies ng mother. So 3 living babies, okay? 3 living children. Kasi 2 preterm twins and 1 term baby. Okay, so it's term child. Ayan. So 3. So nakita nyo, sa F at sa P, isa lang ang count ng twins. But what do we do in actual practice? Ganito sinusulat ng mga OB, okay? This is across all hospitals, I've noted. Sa F at sa P, kinakount mo na yung number ng babies. Okay, so if you have had 2 twins, 2 babies, meaning twins, dun sa previous pregnancies mo, so counted yan as 1 sa P, but yung FP mo, magre-reflect na rin yung number of babies. So 0, 2, and of course 0, 2 if buhay pa rin yung twins. Okay, bakit ganun? Bakit iba yung OB, iba yung sa textbook? So guys, hindi tayo, since clerks and interns kayo, hindi pa kayo magbo-boards. Siguro pag nag-boards kayo, we will follow blueprints, okay? But since you are rotating as OBGYN clerks and interns, we follow the notation of most Philippine OBGYNs, okay? So 0202 yung gagamitin natin. Bakit? So this is one possible explanation behind this. Okay, so sabihin natin, okay, may twins ka. Si twin A, yung first twin, we usually label the twins twin A, twin B, okay? Si twin A, the first twin died, okay? So early neonatal death. Yung neonatal death is death of an infant within the first 28 days of life. You label it as early pag within the first 7 days of life siya. So unfortunately, namatay kasi preterm daw eh. So namatay si twin A. So may early neonatal death. So ang OB score mo niyan, sa notation ng POGS, sa notation ng most Philippine OBGYN, 0201. So nag-get nyo, magre-reflect pa rin sa OB score mo na twins yung previous, yung P1 niya. Nagre-reflect pa rin siya. Pero kapag halimbawa ipa-follow mo si blueprint, 0101, it's as if yung first pregnancy niya was a singleton or a single baby lang yung lumabas. Hindi magre-reflect yung status or yung multifetal gestation doon sa FPAL score. Nag-get nyo? I hope that's clear. So, Doktora, Doc-Shi, ano ba talaga? Alin gagamitin natin? Ito guys, itong naka-red, yan yung gamitin natin. Okay? At least for your rotation. So far, hindi pa to tinatanong sa boards kasi it's very confusing din. Dahil iba yung nasa textbook, I guess, and kung ano yung ginagawa sa practice. But for your rotation, guys, ito yung gagamitin natin. Okay, si 0201 for this one prior preterm delivery na may twin A na nag-early neonatal death. Okay? I hope that's clear. Okay, so other terminologies. So time of fertilization until 8 weeks or 10 weeks gestational age. So magkaiba to guys ha, magkaiba itong time of fertilization. This is what you call developmental age. Tapos ito yung AOG, 10 weeks gestational age. Magkaiba yan, mamaya explain ko. Ang tawag doon ay embryo. I won't go into the details, pero bakit important na alam mo kung ano yung embryonic period? Because during the embryonic period, nandyan yung blastulation, gastrula, ganyan. And ang pinaka-importante, that's where your organogenesis begins. Okay? So this is when your baby is formed. So after 8 weeks until the time of birth, your conceptus is called fetus. Okay? So kapag meron kang 7 weeks sa ER, wag mong tawagin yung conceptus niya na fetus. Dapat ang tawag mo doon embryo. Okay? Nasa embryogenesis, nasa organogenesis pa lang yan. So embryo ang tawag mo doon. But beyond 8 weeks, until 29 weeks, until kung ilang weeks man siya ipanganak, you call the conceptus fetus. So if the embryo is embryonic period is a time for your organogenesis or when your conceptus is developed, your baby is developed, your fetal age, your fetal period, this is when the baby grows and develops. More of growth and development. Okay? So between delivery to 1 year, infant, yung technical term dyan, and then term, 37 weeks to 42 weeks. Minsan, hinihimay pa namin yan late preterm, early term, late term, ayan. Pero for your level, enough na sa amin na alam nyo na 37 to 42 weeks ay term pregnancy. Okay. So let me make a clarification, guys. Itong basic terminologies na to, this table is based on what's written in the first chapter of your Blueprints OB/GYN, which is the Bible or the main reference book for the board examination. But okay, let me make a clarification regarding post-term pregnancy. Okay, ito yung definition ni Williams ng post-term pregnancy. Beyond 42 weeks or greater than 294 days past the menstrual period. Meaning, ang 42 weeks considered post-term na siya. Okay? Post-term na ang 42 weeks. Malinaw tayo doon. How about kung sabihin ko 42nd week? Post-term na ba yun? Pag sinabi ko na yung patient is in the 42nd week. So, hindi pa yun considered post-term. Why? Because ang 42nd week is from 41 weeks to 41 and 6. Malinaw? So, ito yung 42nd week. Yung 42 weeks and above, yun yung considered post-term. Doktora, ano ang difference ni post-term kay post-mature? Si post-term refers to the pregnancy. Si post-mature refers to the baby. Okay? Post-maturity syndrome, sa baby yan, dinidescribe. Si post-term pregnancy is yung duration ng pregnancy. So yung mga post-mature babies or yung may post-maturity syndrome, they have a classic appearance. So mukha silang matanda, no? They look wrinkled, worried looking, unusually alert. Yun yung some of the descriptions ni Williams ng mga post-mature babies. Doktora, do we still use the term post-datism, post-date? Wala na yon, hindi na yon. Hindi na ginagamit yung mga terms na yon. We really just refer to post-term pregnancy as post-term pregnancy depending on the AOG of the patient, and post-mature or post-maturism kapag baby yung dinidescribe mo. Okay, malinaw? Kunwari, ang LMT ko is this one. This is the first week of January. Yan yung LMT ko. Ang LMT, hindi siya same as the time of your ovulation. Kailan ka mag-ovulate? Mag-ovulate ka 2 weeks pa after that. Okay? At this point. So dito yung, at this time, ito yung time of fertilization kasi this is around the time of ovulation also. That is why, so kung yung AOG mo is dependent on your, so if your AOG is dependent, or gestational age is dependent or is based on your LMP, your developmental age or your time of fertilization, ito yung sinasabi niya dito, time of fertilization until 8 weeks, 2 weeks after pa yan. Okay? That is why always mas malaki by 2 weeks yung gestational age by your developmental age. So ano yung mas ginagamit namin? Yung based on LMT or your gestational age or AOG, age of gestation. Malinaw? Okay? Okay, let's move on. So how do you date the pregnancy? So na-mention ko na kanina, no? So ang common way is to ask the patient their LMT, their last menstrual period. Actually, the longer term for this is your last normal menstrual period. Kasi yung iba, di ba, after implantation, may konting spotting, hindi mo yun ika-count as your LMT. Your LMT or your last menstrual period should be yung last normal period niya. So dahil period siya, usually we note it as a period. So example, October 2 to 5, kung mga 3 days siyang nagme-mens. So ang basis ng aging mo is the first day, unang labas ng regla. So that's your October 2. Yun ang LMP ng patient mo. We usually ask also the previous menstrual period just to check how regular the patient is. So kailan po kayo, bago po nung October, nung September po ba, niregla po kayo? Opo, doktora, bago nung September, niregla din kayo nung buwan before that? Yes po, doktora. Okay? Pero yung in terms of dating, yung LMP lang guys ha, hindi na yung previous menstrual period, just to check for yung regularity. Okay, so what if your patient, minsan hindi nila sa ulo yung LMP eh. Sometimes hindi nila ma-recall yung exact date, or doktora kasi irregular po ako, hindi ko talaga maalala. Hindi ko talaga alam yung LMP ko or yung unang regla ko or nung unang araw ng huling regla ko. Hindi ko po siya maalala. Anong naalala niyo, ma'am? Huwag niyo pagalitan yung patient ha. Maghanap kayo ng ibang way to date the pregnancy. Doktora, nagpa-ultrasound kasi ako last week. Okay? So bihirang-bihira ka makakarinig ng patient na, doktora, nung March 3 yung baby ko po, 5 weeks and 4 days. Okay? Bihirang-bihira ka makakarinig ng ganong patient. Ang maririnig mo usually and what they will pay attention to is the due date. Okay? So, base po sa pinakaunang ultrasound, ano po ang due date nyo? So, yan usually ang sasabihin sa inyo ng patient, doktora, base sa pinakaunang ultrasound, ito po ang due date ko. You usually ask kung ano yung first. Okay? Yung first ultrasound due date. Yung mga succeeding kasi, it will be less accurate. So you ask yung patient, ano po yung pinakauna yung naaalalang due date? Okay? Ilang buwan nun si baby? Ganyan. It's also important. Maganda ding i-note nyo yun. Kasi pag less than 12 weeks, ginawa yung ultrasound, tapos naalala nyo yung due date niya, accurate na accurate yan. Okay? By 4 days. Okay? Plus minus 4 days. Okay, so sabihin na natin due date yung naalala ni ma'am. Very good, at least may naalala siya. So yung due date na yon, that is designated as your expected date of delivery. It may also be called EDC instead of EDD or estimated date of confinement. Kaya minsan, pag tinitingnan yung mga OB histories namin, what you will notice is we put pregnancy uterine 39 weeks by EDD or by EDC. Okay? Kasi ito yung ginagawa naming basis. So, ang EDD mo kasi at EDC, that is the time that the baby will be 40 weeks. Okay? 40 weeks siya, AOG, or 280 days, which is the mean period of duration of your pregnancy, 40 weeks. Yun ang due date. Okay? Kaya minsan, may consult ka sa ER, doktora, overdue na ako. Ibig lang nilang sabihin, 40 weeks and 1 day sila. Okay, so how do you compute the date of your pregnancy, the age of your pregnancy or your gestational age based on your LMP? So may manual method, okay? So for example, ang LMP ko is November 25. So there are 30 days in November So 30 minus 25, 5. So December has 31 days, so plus 31. Tapos, so, pwede mo siyang i-manual. Tapos, halimbawa ngayon, the day-to-day is January 5, so plus 5. So, the sum of that, divided by 7, yun yung ilang weeks siya. Pwedeng ganon. Pero pwede din namang huwag na kayong magpakahirap, lalo na pag marami kayong consult, marami kayong OPD patients, you're free to use an app. So, my favorite app is this, OB Wheels. Okay? So, ang maganda sa app na to is you can base your aging on the LMP, pwede rin sa sonodate or the EDD. So kapag sinabi mo na, pag ito, di ba, sabi ni patient, ang naalala niya lang is the EDD or the estimated date of delivery. So sinabi niya sa'yo, Doktora, September 10 this year, yun daw po yung due date ko. So ilalagay mo dito, 40 weeks. Okay? So pag nilagay mo dyan na 40 weeks, i-compute niya sa'yo automatically. So the patient is currently 5 weeks and 2 days by EDD. Na-get? Malinaw? Okay, so pwede rin naman, baka stellar yung patient nyo. O, Doktora, yung ultrasound ko nung today, January 10, 5 weeks and 2 days ako. Okay, ang galing. So naalala niyo yun. So automatically, based on the day-to-day, it will compute for you how many weeks AOG na si baby. Okay? Sige. So kapag wala talaga, Doktora, wala talaga ang perang pang ultrasound. Wala rin ako maalala, Doktora, irregular po ako eh. Irregular ako, tapos wala akong kalendaryo sa bahay. So, one rough way of dating your pregnancy is by quickening. So, quickening is the time, yung first perception ng movement ni baby. So, if you're a premi-gravid, if you're a G1, this is around 18 to 20 weeks. So kapag multi-gravid ka na, G2 and above, this comes earlier, 16 to 18 weeks. So, Doktora, last week, first galaw ng baby ko, G3 na ako. So you can estimate na siguro si mother is between 17 to 19 weeks. So, by quickening, okay? So, hindi naman to usually pinu-pursue, okay? Meron kami ibang ways of dating the pregnancy. Pag walang-wala na lang talaga, okay? You can date your pregnancy based on the quickening, based on the estimated time for your premi-gravid and your multi-gravid kung kailan nila first mapaperceive na gumalaw si baby. Okay? Nag-get? Pero as you can notice, okay, parang siguro as you can assume, very variable to. Di nila sure, hindi ko sure kung sumipa siya, Doktora, or kabag ko lang. Okay? So this is very inaccurate. So we really push for an ultrasound if talagang walang-wala. Hindi alam ng patient yung aging niya. Okay. So when do you use your LMP or your ultrasound? Kailan? Okay, so just a note about ultrasound. When you see early ultrasound, this is less than or equal to 20 weeks. Okay, so yung time ng abortus pa siya, 20 weeks below, early pregnancy, early ultrasound yung tawag doon. Kaya papansinin niyo yung mga diagnosis namin, pregnancy uterine, 25 weeks by early ultrasound, you can assume that the ultrasound was done at less than 20 weeks. Pag sinabi mong late, this is beyond the age of viability, so more than 20 weeks. So alin ang mas accurate? Of course, mas accurate si early. Okay? Mas maagang ginawa yung pregnancy, especially during the first trimester at less than or equal to 12 weeks. Okay? Yan yung accurate na accurate. Okay? Kasi sobrang liit pa nung conceptus mo, kita mo in one view yung entire baby, your crown rumplets. You will see the entirety of that in one view. So that is one of the most accurate ways of dating your pregnancy. Okay? So, kailan ka gagamit ng ultrasound instead of LMP? So, una, kapag unsure of menses. Doktor, hindi ko talaga alam kailan ako huling niregla. Pangalawa, Doktora, may PCOS ako eh. Regular ako, parang every 5 months po akong nagre-regla. Okay, obviously, you can't use your LMP for those cases. Later on, I will explain to you why missed abortion, you have to use the ultrasound instead of the aging by LMP or by amenorrhea. Later on. Okay? Pero keep this in mind. So for missed abortion, halimbawa, 12 weeks siya by LMP, pero ang nakita mo sa ultrasound, meron siyang missed abortion at 7 weeks. What you will label the patient is missed abortion, 7 weeks AOG. Na-get? Hindi natin i-label siya as 12 weeks AOG. Ang igagawin nating basis is your ultrasound na nag-note kung kailan yung missed abortion. Okay? Yung first documentation ng na walang heartbeat yung baby. Later on, we'll go back to this thought. Okay? Pag diniscuss ko na yung early pregnancy complications. Okay. Next, kailan ka gagamit ng ultrasound dating? It depends on the discrepancy between the aging based on your LMP and your ultrasound. What do I mean by this? So this is found in Williams, and this is prescribed also by your ACOG. Doc, memorize ko ba to dapat? Okay, let's go back to the app. Okay, pag pinindot mo to, itong ano na to, Reconcile LMP and Sono EDB, ito siya. Okay, this is found in Williams. So kailangan better if you memorize this. So isipin nyo na lang kung nahirapan kayong i-memorize as the aging, as the gestational age increases, mas mataas yung discrepancy na kailangan ma-fulfill para yung ultrasound yung gamitin mo. Okay, Doktora, explain. Hindi ko maintindihan kung anong sinasabi mo dyan. Okay, bigyan ko na lang kayo ng example. For example, meron kang patient na 8 weeks by LMP. So ito siya, di ba? Gestational age. So this first table, ang titingnan mo dito is the aging based on LMP. Okay, sabihin natin 8 weeks siya. So less than 9 weeks. Ito, di ba? However, dun sa ultrasound na ginawa sa kanya nung 8 weeks siya, 7 weeks lang, doktora. So ano po ba talaga siya? Is this patient 8 weeks or is this patient 7 weeks? Importante yan kasi kapag later on nagkaroon siya ng sakit, it will matter kung i-admit mo siya this week or next week or the week before this. That's important. So, 7 weeks siya by ultrasound. So, you have a discrepancy of more than 5 days. So, na-reach niya yung threshold to revise. Therefore, what you will use is the aging by ultrasound. Na-get? Kapag pumasok siya dito sa threshold to revise, this is threshold to revise the aging, meaning hindi mo titingnan tong by LMP, rather you will base it on the ultrasound. Na-get? Okay, so let's give you another example. Okay, 10 weeks by amenorrhea. So LMP by amenorrhea, same terms, okay? So sometimes ganun niyo siya mababasa sa chart. 10 weeks by amenorrhea. So 10 weeks by amenorrhea, so dito siya pasok, di ba? Sa second row. Between 9 to 14 weeks, ang difference niya ay 5 days. Okay. So since ang difference niya ay less than 7 days, hindi niya na-fulfill yung more than 7 days, what we will follow is still the LMP. Na-get? Okay. I hope that's clear. So ang gagamitin natin is LMP. Kahit less than 12 weeks itong ultrasound na to. Doktora, akala ko ba ito yung pinaka-accurate? The way we report it is yung aging niya by amenorrhea is compatible with her early ultrasound done at 10 weeks. So, ibig sabihin, good ka. Nagko-coincide yung LMP mo and your early ultrasound. So, okay lang kahit yung LMP yung gamitin nating basis for dating of pregnancy. Na-get? Okay, pag hindi nyo na-get, download the OB Wheels app. Meron doon, Reconcile LMP and Sono EDB. Okay? So magandang sa ulo nyo to, pero okay lang din for your first few days in the rotation na you go back to the wheel para para ma-familiarize kayo with how you redate based on ultrasound. Alright. So we have a rule called Nagel rule. So this is EDB based on LMP. So paano siya? Paano siya ginagawa? So you subtract 3 months from your LMP and add 7 days to the first day of the last period. Okay, so for example, my LMP is October 5, 2020. So you count back 3 months. September, August, July. So my due date is in July. Tapos October 5. So plus 7 days. So July 12. And of course, you add 1 year. So 2021. So, okay, here's another example. What if your LMP is January 10, 2022? So compute, count back 3 months. So December, November, October. And then 10 plus 7 is 17. So, of course, hindi ka naman mag-a-add ng 1 year kasi yung October 17 ay nagpo-fall naman within 9 months from your LMP. Okay? Na-get nyo? So, ano na lang siya, isang parang for me, common sense na lang siya kung magdadagdag ka ng +1 in the year. So, hindi naman necessarily, that's why I didn't include it here, hindi necessarily mag-a-add ka ng 1 year. Basta you count back 3 months, you add 7 days, and then depends kung nasa latter part of the year or nasa early months yung LMP mo, if you will add +1 or you will retain the year for your EDD or your estimated due date or date of delivery. Okay, so we have another case. We have a patient named Inday. She's 31, naliparous, so P0. Okay? P0 si patient. So hindi natin alam kung buntis to or hindi sa atin nabigay. Basta naliparous siya. So P0. Her chief complaint is spotting. So when you ask her about her LMP, she can't give you an exact date. Pero when you press for it, ang sasabihin niya sa'yo, I think, doktora, around November last week. Okay, so ano ang una mong gagawin? This is a very basic question. Lahat ng residente, tatanungin ko sa inyo. Which diagnostic test should you order first? Simpleng-simple. Urine pregnancy test. It will matter kung buntis or hindi yung patient. So this is where, after the age, gravidity parity, this is the next part of the algorithm. Any reproductive age woman presenting to you as abnormal, with any abnormality sa pagdudugo, pregnancy test. Whether hindi siya dinudugo, meaning amenorrheic, or kapag may abnormality sa pagdudugo niya, like may spotting in between menses, or sobrang lakas ng menses, pregnancy test. Doktora, wala po akong pakipagtalik, hindi yan magpa-positive. Syempre, hindi mo pwedeng pilitin yung patient, but you have to explain to the patient na, ma'am, magmamatter po kasi siya sa management natin kung kayo ay pregnant or hindi. Ginagawa po siya sa lahat po ng pasyente na nagre-regla pa rin po na may abnormality po sa pagdurugo. Okay? Sa vaginal bleeding, pag mag-represent ng vaginal bleeding. Okay? So just explain well to the patient na kailangan siyang gawin kahit nagde-deny yan ng coitus. Okay? Hahanapin kasi talaga yan ng pagre-referan nyo na OBGYN, yung pregnancy test. Okay, so 31-year-old, naliparous, never had a pregnancy beyond 20 weeks, may spotting. So, okay, sakta lang, tama. Nag-pregnancy test naman si intern or si clerk. So, next question. So, sabihin natin nag-positive si Inday. So, G1, P0 na siya. So, which hormone does your pregnancy test? So, redundant, no? So, which hormone does your pregnancy test for? Tama pala. So, basically, ano yung hormone na dinidetect niya? So, what it's testing for, whether sa urine or sa serum, okay, is your beta HCG. Note the alpha letter before your human chorionic gonadotropin. It's the beta subunit, okay, of your HCG. Yun ang dinidetect ng pregnancy test. Okay, board exam question. Okay, favorite. So the following statements regarding beta HCG are true, except, so alin dito ang false about your beta HCG? So isa-isahin ko ha, for you. First, its alpha subunit is similar to that of your TSH, LH, and FSH. So these hormones, these are your other pituitary hormones. So second, it declines after 10 to 12 weeks and plateaus after 15 weeks. So by 16 weeks, nagpa-plateau na siya. Is that true? Third, it is mainly produced by the corpus luteum until the placenta takes over. So last, it may be detected in the maternal serum or urine 8 to 9 days after ovulation. So this is around 3 weeks after your LMP. So ito ba ay, alin dito ang tama, alin ang mali? So let's talk about the beta-HCG because this is a very important hormone for us. So your human chorionic gonadotropin or your HCG has two subunits, your alpha and your beta subunit. Now your alpha subunit, yung subunit na yon shares a similar structure with that of LH, FSH, and TSH. Meaning yung alpha subunit nitong hormones na to, same lang siya with that of HCG. This is the reason why yung beta yung tinitest natin kasi siya yung unique sa HCG. Naget? Okay. So urine test and serum assays test for the beta subunit as I mentioned. It may be detected in the urine and serum 8 to 9 days post-ovulation. So ito medyo highfalutin to, di nyo to magigets. Pero ito siguro. Ito, importante to. If you are watching out for pregnancy or if you are anxious right now if you're pregnant or not, kailan siya magpa-positive? Yung urine pregnancy test, yung PP kit na makikita mo sa Mercury or in your convenience stores. So it will test positive around the time of the missed menstrual cycle. What do I mean by this? So for example, my LMP is December 15. I'm regular naman. Pagdating ng January 15 the next year at hindi na ako nagkaroon or January 17 o basta around this time, pag hindi pa rin ako nagkakaroon ng menses and I know that I'm sexually active, I will do a pregnancy test, okay? Magpa-pregnancy test ako because it will already show you a positive result if you are pregnant. Very rare yung mga false positive results ng pregnancy test. So kapag halimbawa faint lang, minsan faint lang yan eh. Kahit faint na line that's already considered negative, hindi yan mag-show up in any form kung ikaw ay hindi pregnant, okay? So kahit super faint na second line, positive yan. That's considered positive. Okay? Hindi kailangan ganito ka-bright red yung test line. Alright. So saan na-perform yung anong nagpo-produce ng HCG? The one that produces your HCG is your placenta. Okay? Your syncytial trophoblasts are the ones that secrete your HCG. So ano ba ang point ng HCG? Basically, your HCG, its point is to maintain the corpus luteum. Okay, so ano si corpus luteum? Si corpus luteum, basically, kapag nag-ovulate ka, siya yung matitira sa dominant follicle mo. Okay? Siya yung parang wrapping, for lack of a better term. Kumbaga siya yung surrounding structure around your ovum, your egg. So kapag na-release mo na yung egg, what remains inside the ovaries is your corpus luteum. Now, corpus luteum is very important because it's a temporary endocrine structure, meaning naglalabas siya ng hormones for a short period of time. So, yan, as I mentioned, placenta produces the HCG. Ang point lang ng HCG is to make sure that the corpus luteum lives. Why is the corpus luteum important? Kahit pinaghubaran lang siya ng egg. It is important because it produces your progesterone. And your progesterone is the one that maintains your pregnancy. Isipin nyo guys, bakit hindi kami nag-oopera ng mga ovarian new growth ng less than 6 weeks, ng mga nasa first trimester? It's because we are afraid of violating the ovary with the corpus luteum. Kasi kapag tinanggal namin yung pag na-violate namin yung corpus luteum, you will be withdrawing progesterone. And what will happen is you could abort the baby. So progesterone is important in maintaining the endometrial milieu that is suitable for your pregnancy. Na-get? Okay. So yun ang point lang basically ni HCG. So si corpus luteum, eventually 6 weeks, magde-degenerate na yan. So sino na ang mag-produce ng progesterone? So after 6 weeks, unti-unti nang nagte-take over yung placenta. So as your gestational age develops, your placenta also develops, nagiging siya na yung main source ng progesterone. So okay na, pwede nang i-dispose ng body yung corpus luteum. Okay? But in the meantime, while this is happening, kailangan i-maintain ng placenta through HCG yung corpus luteum, the main source of this very important hormone, progesterone. if you've ever had threatened abortion in your lifetime, or kung may patient kayo na merong threatened abortion, note na most of our therapeutics are given in the form of progesterone, either iniinom or intravaginal progesterone. So that's how important progesterone is. Okay, so other notes about HCG. So it doubles every 48 hours in a normal pregnancy. So kapag halimbawa, exponential kasi ang growth nito eh. So for example, today, I test my beta HCG. After 2 days, kung normal yung pregnancy ko, dapat kung 1,000 ngayon, magiging twice siya. Magiging 2,000. And after another 48 hours, times 2 ulit. So 4,000, ganun, etc. Okay, I'm not very sure with the particular values. We have a table for that in the OB Platinum. Okay, please support. Okay, so halimbawa, nag-beta HCG ako ngayon. Tapos, 1,000. After 48 hours, bumaba, 800 na lang or even 1,000. So magiging worry ako na baka hindi viable yung pregnancy ko. Baka hindi to normal pregnancy. Kasi ang expectation mo is every 48 hours, dapat nagdo-double siya. Okay? So this is important kapag wala kang makita sa ultrasound, tapos, pero biochemically buntis ako. Ano ako, doktor eh? Serong HCG, meron. CT, meron. Bakit walang laman yung matres ko? Bakit walang adnexal mass, walang ectopic? So for pregnancies of unknown location, this is an important clinical correlate, this fact, that the HCG doubles every 48 hours. Okay, so this peaks at 10 to 12 weeks, and it declines to reach a steady state after week 15. Some references, they will say 16 weeks magpa-plateau. So essentially, kapag week 15, week 16, nagpa-plateau na yan. Okay, so this is the value, 100,000 milli-IU per ml. Sometimes this is reported as IU per liter. That's the same lang. By 10 weeks, then it will level off around this time in the 3rd trimester. So as I mentioned, the placenta produces HCG to maintain the corpus luteum. So very important, very important. Do not forget that fact because that makes letter C the one incorrect statement here. So tama naman to. Alpha subunit is similar to the other pituitary hormones like your thyroid hormones, your LH, FSH. So tama to, mention ko lang nito. Anong mali dito sa statement nito? It is produced dapat by the placenta. Okay? So ang dinidescribe actually ng letter C is your progesterone. Okay? So it is produced mainly by your corpus luteum until your placenta is old enough to take over in the progesterone production. Okay? So ito, tama din to. So guys, around the time of menses, if you are sexually active, walang mawawala kung magpe-pregnancy test. Okay? Just to make sure that you are not pregnant. Okay. So, sige, same pa rin. Same patient, si Inday. 31-year-old naligravid. So these are the components of your psychosocial sexual history. So you note the vices, smoking, drinking, alcohol. Later on, I will tell you why I highlighted this kasi may mga important aspects about the vices that we need to take note. Religion. So this is important kasi OB is a bloody business. I forgot which page in Williams that is stated, pero kapag Jehovah's Witness po, as you know, we can't do blood transfusion. So that's one of the important notes that you have to take into consideration when you do psychosocial and sexual history. That's why we ask this. So other things that you can ask are patient's educational attainment, occupation. So sa sexual history, first coitus. So bakit importante yung first coitus? Kasi di ba pag halimbawa malapit sa menarche, ikaw nag-first coitus, so very prone kayo na magkaroon ng persistent HPV infection. Or kapag halimbawa, yung number of sexual partners mo ay marami, so that predisposes you also to HPV infection. So important then to ask if the partner of your patient is promiscuous or non-promiscuous. Okay, and also history of STD or your sexually transmitted diseases. So kapag meron silang history nun, you ask kung ano yung mga naging prior treatment nila. So that's important. Contraceptive use, this is also important for us. Nag-pills po ba kayo, nanay? Nag-injectable po ba kayo? Nag-IUD? Okay? So yun yung mga tatanungin natin. Because that will also change our management. So for example kasi, naka-DMTA yung patient mo for 1 year. Ang chief complaint niya sa'yo ay spotting. So immediately, alam mo na agad. So you know that DMTA, one side effect is that there could be spotting. Isa yun sa mga nirereklamo nila. Kasi pag may naka-injectable ka, your endometrium becomes atrophic. So, kumbaga, kumikis-kis yung anterior and posterior endometrium. That is why there is spotting or bleeding. Breakthrough bleeding when you have, when you're being given DMTA or your injectable. So, importante yun. Take note of that. So, other things to note. So, in terms of vices, pag buntis yung patient mo, you know that smoking predisposes your patient to a lot of disorders. Okay, I have a question for you. Okay, lahat to, di ba? Marami kang kalaban if you're a smoker and you're pregnant. So you can have stillbirth, placenta previa, preterm delivery, etc. Medyo given na to kasi kumbaga papangit yung utero-placental milieu mo kapag ikaw ay nagsusmoke kasi may hypoxic. May hypoxia component. Pero, what is the one thing, what is the one disease na instead of, what do you call this, na hindi siya risk factor. Ironically, hindi siya risk factor. Sometimes, sinasabi pa nila protective. What is this one disease na okay ka? I mean, na hindi ka magkakaroon, na you less likely have if you're smoking. So, ironically, ang smoking is not a risk factor for pre-eclampsia. Okay? That's a very interesting fact. So, para siyang endometrial cancer. Protective pa siya against endometrial cancer. So, yun din yung something unique, something that might be asked in the board. If you're smoking, ironically, is not a risk factor for your pregnancy-induced hypertension or your pre-eclampsia. Okay? Sometimes protective pa siya. We don't know the reason why. May mga postulates about it, but basically, yun siya. Kung papansin niyo walang pre-eclampsia dito. Kahit expect mo siya, di ba? Smoking, edi mas likely kang mag-high blood. But no, in the books, both in Blueprints and in Williams, smoking is not a risk factor. In fact, it could be protective against your pre-eclampsia. Okay, your fetal alcohol syndrome, isa din to sa mga favorite questions namin. So there is a triad for your fetal alcohol syndrome. So if you drink during your pregnancy, especially during the embryonic period, so that is until 8 weeks from fertilization or 10 weeks AOG, you will have this triad. First, growth restriction. Second, facial abnormalities. May specific fascies na to, pero sige, I will leave that up to you for your reading. And CNS dysfunction. Okay, so that's your triad for your fetal alcohol syndrome. So huwag kayong inom ng wine, especially during the organogenesis, especially during the embryonic period. Okay, bawas-bawasan yan. This is also the reason why kapag nakainom ka, first trimester mo, hindi mo alam buntis ka, nag-New Year's Eve party ka. So pag ganito, pag na-elicit yun sa'yo ng OB mo, ipapa-congenital anomaly scan ka niya during your second trimester to look for these things in your baby, okay, in your fetus. Illicit drug use, so these are the things, these are the comorbid conditions that you are predisposed to when you have illicit drug use. Okay, so next part. So tapos ka na sa psychosocial history ni Inday, now you go to the menstrual history. So para maalala namin yung menstrual history, we use the mnemonic MIDAS. M stands for menarche. Obviously, this is the age during the first menses. Next is the interval. Usually, pag hindi naman kami OC, we write regular monthly intervals. Meaning, your menses has an interval or days between 28 plus minus 7 days. So why did I put this, 24 to 38 days? Kasi kapag yung resident mo, ang tinanong niya sa'yo, o sige, based on the FIGO, revisions, na AUB definition, ano na dapat yung mean interval mo? 24 to 38 days is the new normal. Pero itong 28 to plus minus 7 days, this is easier to remember. For me also, this is easier to remember. Also, this is still in the chapter of your Compre-Gyne, 8th edition. So, nung residency ko, 7th edition pa. There is a new edition that came out last year, I think. So, 28 to 7, plus minus 7 days. This is still in the textbook. So the duration of flow, ito pa rin, nasa Compre-Gyne, 4 to 7 days. But if you will base it on the FIGO 2018 revisions, less than or equal to 8 days. So for the amount, this one, I agree with FIGO on this one, okay? So nasa book 35, it could be up to 60 ml, but this is difficult to quantify unless talagang mini-measure mo yung naka-menstrual cup ka, di ba? But usually, hindi mo to maka-quantify as a patient or even as a doctor. This is very hard to quantify. So the amount is based on FIGO guidelines. This is patient-determined. Depende sa pasyente how it affects her daily living, kung ano yung perception niya. So usually the patient would describe it as heavy, normal, or light. So ito na yung bagong consensus namin. It's patient-determined na the amount of menstrual blood flow. And of course, the symptoms. The most important symptom is dysmenorrhea, or dysmenorrhea is defined as pain associated with the menses, especially during the first day of menses. So ano pa ba yung other symptoms? Kapag may pelvic endometriosis ka and you have endometriosis in your rectum, you could have dysphagia. Doktora, pag nagme-mens ako, napansin ko talaga, masakit tumae. Okay? Sakit mag-poop. Or, doktora, pag time ng menses ko, tapos nagkipagtalik kami, masakit makipagtalik, dyspareunia. Or, doktora, nagkaka-UTI ako, basta may mens ako, sure, masakit, mahapde umihi, dysuria. So, when you see these, you're probably dealing with the patient with pelvic endometriosis. Pelvic endometriosis, meron kang aberrant endometrial glands or endometrial tissues in areas aside from your endometrium. Okay, so I will discuss that in the gyne part. Okay, pero basically, ang importanteng i-ask sa symptoms is this one, the symptom of dysmenorrhea. Okay, all right. So sa FIGO guidelines, guys, ang AUB, it's either kulang sa menses, sobra-sobra ka sa menses, or hindi ka nagme-mens at all. So when do you investigate? So eto guys, this is based on Compre-Gyne, the latest edition, and also based on ESRM. So ESRM is the American Society for Reproductive Medicine. So if you have no menses by the age of 15, I'm mentioning the source kasi malilito na naman kayo pag nag-aral kayo sa board. 16 years old kasi to sa blueprint. But okay, for your rotation, 15 years old, okay? In the presence of secondary sexual characteristics. Ano yan, doktora, yung secondary sexual characteristics? These are your breasts, your pubic hair. So kapag meron ka nun, and you're already 15 years old, you're still not menstruating, you have to be investigated for a source or a cause of primary amenorrhea. When you say primary amenorrhea, never had menses in her lifetime. Secondary is kapag nagme-mens ka and then it stopped for a certain period of time. Okay? So these are the times that you have to investigate. Also, if hindi ka pa nagme-mens from the TELARC or from the time that your breast buds began to develop, if this happened before 10 years of age. Okay, so ito, hindi naman siya AUB, hindi naman siya amenorrhea, but if wala ka pa rin breast development by the age of 13, you have to have your investigation for primary amenorrhea. Na-get? Okay, so 15, 13, and 5 years from TELARC. So these are the instances when you have to investigate. All right? Zoom. Okay, now we have a new patient for you. Mag-move on na tayo from the previous patient. So we have Joy. She's 38 years old. She's a G5, P2, 1122. Okay, so ginawa ko mas complicated yung kanyang OB score para mas may ma-discuss tayo. So when you see obstetric history, iba pa to sa obstetric score. Si obstetric score mo, overview mo lang yon. Kanina mo lang yun. Parang part yun general information for us ng patient. When you say OB history, hihimay-himayin natin each pregnancy. Okay? So what we take note of is the year of the pregnancy, the AOG, sometimes enough na for us na term, kung term lang naman. Pero kung halimbawa preterm, kindly note for us kung gaano ka preterm. Bakit importante kung gaano ka preterm? Kasi sa next pregnancy mo, pwedeng maulit na around that AOG. Halimbawa, 28 weeks, nag-deliver ka na, pwede kaming, sa next pregnancy mo, mas worry kami na, magto-28 weeks na to, baka mag-preterm labor na naman to. Okay, so that's important for us. Next is the mode of delivery or the procedure done on the patient. Next, place of delivery. Okay? So important to sa amin, especially if you have questions regarding your case, etc. Okay, next is the outcome or the status of the baby. May complications ba tong baby? May sakit ba yung baby? Living ba tong baby from this pregnancy? So si Joy, ano ba ang kanyang complicated OB history? So isa-isahin natin. So for our G1, it was in 2012 term, okay, so more than 37 weeks. The mode of delivery is NSD or normal spontaneous delivery. Sometimes they call this SVD or spontaneous vaginal delivery. Sa puwerta po lumabas yung anak ko nung first pregnancy. Sa PGH po ako nanganak. Buhay naman po nung pinanganak, buhay pa rin siya ngayon. Wala naman pong complications yung baby na to. Walang naging komplikasyon. Yun lang yung wala kang komplikasyon na pagbubuntis. Okay? Yung second pregnancy niya nung G2, this was in 2015, around 8 weeks. Spontaneous abortion. Why do I need to say na spontaneous? Meron bang non-spontaneous? Guys, unfortunately, there are cases of induced abortion. Okay? So, spontaneous abortion naman nung 8 weeks. Pero hindi naman po ako niraspa. Okay? Dinugo lang po ako nun. Hindi po ako niraspa. Noong 2018, preterm. Sabihin natin 8 months. Ganyan, around 32 weeks. Mode of delivery, primary low transverse cesarean section. Para saan po kayo na CS? For placenta previa. Okay? Ako, kapag nag-explain ako sa pasyente ko, ang ginawa ko pong cesarean section sa inyo, pa-smile po sa ilalim na portion ng mattress nyo. Ibig sabihin, around 18 months from now, kapag nabuntis po kayo, pwede po kayong mag-normal. Okay? That's one of the reasons why the mode of delivery, the kind of delivery, and the CS scar is important to note. Magbabago to kapag siya ay mayroong classical cesarean section scar. Hindi ka na pwedeng mag-VBAC or vaginal birth after cesarean section. So that's just one of the things na important kung bakit kailangan kong i-note kung anong klaseng operative technique for your cesarean section and ano yung indication. Why? Pwedeng maulit yung indication, di ba? Pwedeng may placenta previa siya ulit sa next pregnancy niya. So, saan ginawa po? Saan po ginawa yung CS nyo? Sa hospital ng Makati. So, ano po nangyari dun sa baby? Buhay naman po. Live birth, buhay hanggang ngayon. Kulang po siya sa buwan. Tapos yung baby ko po, nalaman na meron po siyang sakit sa puso. Okay? May butas po siya sa puso. So, this is important to note. So, other diseases na pwede mong i-elicit or pwedeng ma-elicit, doktora, yung baby ko po may hydrocephalus, yung pangatlo ko. Saka, or doktora, meron po siyang spina bifida. So yun, mga important yun, no? Magmamatter yan sa mga succeeding prenatal check-ups ng patient mo. Next, pregnancy, 2019, nag-ectopic pregnancy siya on the right, sa PGH ulit siya na itakbo, and for that, natanggalan siya ng right fallopian tube. So these are the things that are important to note. And currently, nitong sumunod na year, 2020, she's already pregnant. So since hindi mo alam yung status, it's enough to note na current pregnancy yung G5. So let's check the OB score. Tama naman, G5, no? P2, because you have a term, you have a preterm. These were both carried beyond 20 weeks. 1 term, 1 preterm, 2 abortions, 1 abortion, continuous abortion, and 1 ectopic pregnancy. And 2 kasi buhay, si G1 and si G3. Okay? I hope that's clear. So other parts of your OB history na important din i-note. Prenatal checkup history. Ilang beses po kayong nagpa-prenatal? And saan po kayo nagpapa-prenatal? Itong patient na to, Okay, I will try, hindi ako magpapagalit, pero dapat naman sa hospital siya magpapa-check up, no? Kasi meron siyang, kasi scarred uterus ang tawag namin dito. Meron siyang previous cesarean section. So, dapat sa hospital, instead of lying in and health center, magpapa-check. Kasi sila yung makakapag-manage sa patient when the patient delivers at term. Okay? So, ito yung mga important na i-note sa prenatal history. Okay, now we'll go to the physical examination. So, medyo mahaba yung yung history taking namin, but basically the important notes there are that you don't mention female, you mention the age, the gravidity parity, and what's important for us is that you will also include the obstetric history, the menstrual history, sexual history. Okay? Yun yung mga important sa amin. Aside from your HPI, past medical, family medical history, kung napansin nyo, hindi ko na dinaanan yun, no? Kasi those are parts of your history taking that are not unique to OB. What's unique to us, what we really put premium on are your OB history, menstrual history, ayan. Kailangan thorough kayo dun sa mga things na yon. Kasi yun yung mga unique to our specialty. Okay, so now we'll move on to the physical examination. So for this, hindi ko na masyadong ito toxic yung pag-chest PE, okay? So those are important. Let me tell you that. But yung head and neck, okay, yung mga ganung things important yun. But let me focus on the pertinent PE that we look for in our OB patients, okay? So let's move on. So first, general survey. So yung usual lang yan. Awake, conscious, coherent, ayan. So, same lang naman as other specialties, okay? Not in cardiorespiratory distress. And next is your vital signs. So, I highlighted this because I would like to highlight one disease entity kasi very common to. So, babalikan ko to. So, vital signs, your usual. Your blood pressure, heart rate, respiratory rate, temperature, we note those. And during this time, pati O2 saturation, we already look at those things now. Next is the height and weight. Okay, so we look at this kasi tinitingnan namin yung weight gain nila, especially second trimester above. Okay, so tinitingnan namin how they gain their weight. And then the BMI, we compute it based on the pre-pregnancy weight. Okay, kasi syempre, obviously, obese yan or overweight yan. If you base it on their current weight, if they're in the second trimester or in the third trimester. So we compute the BMI based on the pre-pregnancy weight. So next is, one important note for us is abdominal examination. So focusing on the abdominal examination, these are the things that we look for. The fundic height, the fetal heart tone, and your Leupold's maneuver. Okay? So ito yung mga special parts of your physical examination that we do as obstetrician gynecologists. So next is your pelvic examination. So another unique thing na I think kami lang yung gumagawa routinely. Internal examination, when you insert 2 fingers into the vagina. You can also do your rectovaginal examination, although this is not routine sa mga OB patients, more of the gyne condition. Pag OB patients, enough na for us yung IE findings. Next is your speculum examination. So you use a speculum to visualize the cervix and the vaginal walls of your patient. Later on, we will show you a video with the speculum examination and pelvimetry. Okay, so this is another important aspect of the physical examination. Yung pelvimetry, I will discuss this later on sa labor kasi mas appreciate nyo siya in relation to labor, okay? Next. Okay, so as I mentioned, why do we take note of the weight of the patient? Kasi meron tayong normal na weight gain. So in the second to the third trimester, normally if your pre-pregnancy BMI is normal, dapat mag-gain ka ng 1 pound per week. Okay? So kung nakita mo yung patient at 24 weeks, next consult niya sa'yo, 28 weeks, dapat nag-gain siya ng 4 pounds. Okay? So note nyo guys, kaya naka-blue to, kaya naka-highlight to, you will find this table in Williams. Kaya siya naka-highlight kasi parati siyang tinatanong. For normal BMI, for patients with normal BMI, this is for the entire pregnancy na ha, 25 to 35 weeks, that's your average weight gain. Madali lang yan maalala. So the rest, I will leave that up to you. Okay, just take note, guys, na hindi to yung Asia Pacific BMI. Mas strict sila sa Asians, okay? 23, pag pumata ka ng 23, 24, you're already overweight. Diba? Ganun sa Asians. Between 25 to 30, you're already obese one. Diba? Kung papansinin nyo dito, overweight pa lang yon. So, this is for Caucasians. Pero yung Asia Pacific, it's mas maliit yung BMI cut-off. Okay? Pero yung nasa book and yung itatanong sa inyo sa boards is this one. Kung anong sa Caucasians, kung anong nasa Williams. So, ang normal weight gain mo, average weight gain mo during pregnancy, if you have a normal BMI pre-pregnancy, it's 25 to 35, okay? 1 pound per week in the second to third trimester. That's the normal weight gain, okay? All right. So why did I highlight vital signs a while ago? So ang una mong iti-take sa patient na vital signs, siguro sabay mo nagagawa, iti-take na important na we look at is the blood pressure. Okay? So bakit? Bakit important yung blood pressure? So we have what you call pregnancy-induced hypertension. So that's your gestational hypertension and your preeclampsia. Now we have a strict criteria for gestational hypertension. If you reach a BP of greater than or equal to 140/90, this is or diastolic of 90 without proteinuria, meaning wala kang end organ damage. So it doesn't manifest as proteinuria, which is seen on urinalysis most of the time, occurring after 20 weeks gestation, and BP levels return to normal 12 weeks postpartum. This means that you have gestational hypertension. If you have proteinuria naman, 140/90 on 2 occasions. Ito din guys, 2 occasions din to, at least 4 hours apart. Same lang yung BP criterion nila. Beyond 20 weeks in a woman with a previously normal proteinuria. So these are your parameters for proteinuria. Either nag 24-hour urine collection ka and you saw that on 24-hour urine collection, meron kang at least 300 milligrams of protein or albumin in your 24-hour urine collection. Pwede rin nag-spot ka na urine protein and creatinine ratio and the ratio of that is at least 0.3, or kapag sa urinalysis mo, may dipstick of at least +1. So ito yung tinatawag ng mga OB na stat-alb. Okay, pa-stat-alb mo nga ito, 140/90. Ang hinahanap namin doon is ito, yung dipstick result. So if it's at least +1, you have proteinuria. That means you have proteinuria. Ibig sabihin, hindi ka na gestational hypertension. So na-get, 140/90, na walang proteinuria beyond 20 weeks, GH or gestational hypertension. Kapag may proteinuria, preeclampsia. Ngayon, ano ang culprit mo behind these hypertensive disorders? The culprit here is your placenta. Okay? So, ang culprit mo bilang placenta, ang culprit, ang number one, actually, ang only treatment na definitive for your pregnancy-induced hypertension is delivery of the placenta. Okay? So, yun lang ang gamot sa preeclampsia. Kailangan ma-deliver yung placenta. Okay, so another note about preeclampsia. Ngayon, hindi lahat ng preeclampsia may proteinuria. Pwedeng negative to lahat ng tatlong to. But in the absence of proteinuria, pag na-fulfill niya yung BP criterion, plus meron siya nitong any of the following. These are called severe features, okay? Thrombocytopenia or platelet count less than 100,000, renal insufficiency, so high creatinine, impaired liver function, specifically twice elevated. Because you could have, like, kung 35 ang normal na cut-off mo per AST, pwedeng 40, okay. Hindi pa yan yon. Dapat twice elevated or 70 and above. Or unexplained right upper quadrant or epigastric pain, you will think of impaired liver function. So that's a severe feature. It's part of your preeclampsia syndrome. So next is pulmonary edema, cerebral or visual symptoms such as headache or visual disturbances. Okay? So I probably highlighted this kasi siguro nagamit ko to in a previous question, no, na may patient siguro ako na both with pulmonary edema and visual disturbances. So kahit wala kang proteinuria, pag mataas ang BP mo, meron ka nitong any of these things, you label the patient as preeclampsia with severe features. Pag halimbawa naman, wala nitong criteria na to, meron lang siyang BP, elevation with proteinuria, preeclampsia without severe features. So dati, requirement sa amin tong proteinuria. And the reason why they removed it from the criteria, from the strict criteria of your preeclampsia, is because sometimes hindi nagmamanifest yung patients with preeclampsia ng proteinuria, pero may iba na siyang evidence of end organ damage, such as thrombocytopenia or renal insufficiency. So actually, mas malala yung end organ damage na pinapakita niya. So pag ganyan, takot na kami niyan. Pag sinabi ng patient sa amin, high blood siya, doktora, nalalabo yung paningin ko. Ang sakit ng sikmura ko talaga, sobrang sakit. Matakot ka na. Baka you're dealing with impending eclampsia na pag ganyan. Okay? So as I mentioned, this is considered severe preeclampsia with severe features. Sorry, we don't label severe preeclampsia kasi walang mild preeclampsia. So we want to emphasize that, no? Hindi na siya mild preeclampsia and severe preeclampsia. Preeclampsia is a spectrum of disease that could only have with or without severe features. So another criterion for preeclampsia with severe features is the presence of an abnormally high BP greater than or equal to 160/110. So kung ito, hinihintay namin at least 4 hours apart, ito, kahit within seconds lang nga or within minutes, kapag na-confirm talaga namin na 160/110 yung highest BP niya, we already label the patient to have severe preeclampsia with severe features. Okay, so bakit important na i-label kung sino yung may severe features, sino yung without severe features? Yung mga without severe features na preeclampsia and gestational hypertension, we don't need to give them prophylaxis for seizure. So ito, masakit to guys. Masakit siya for the patient. Sobrang init sa katawan nito. So we are very worried. Okay? It's not without side effects. Yung iba na nagmamagnesium sulfate toxicity, they can present to you with DOB or difficulty of breathing. So we really choose the patients to whom we give magnesium sulfate. So we only administer magnesium sulfate if the patient has severe features or the patient already went into eclampsia. Okay? Kaya sa pre-eclampsia, prior to eclampsia, so ito yung ayaw sana natin, no? Yung seizures na hindi mo ma-explain ng other etiology that could only be explained by your pregnancy-induced hypertension. That is what we want to prevent or what we want to mitigate with your magnesium sulfate. Okay, so this is our treatment as well as our prophylaxis for your seizures. All right, so as I mentioned already, eclampsia, this is the occurrence of seizures or convulsions that is not explained by anything else. So this is seen in patients with hypertensive disorders of pregnancy. Yung chronic hypertension, pwedeng yung patient is diagnosed before 20 weeks or if it persists after 12 weeks. Bakit? Sabi ko nga sa inyo, di ba, the reason why the patients are having preeclampsia or pregnancy-induced hypertension is because of the hormones coming from your placenta. Kaya siya lang yung treatment mo The delivery of that is the only treatment for for the preeclampsia and your gestational hypertension. Ngayon, if na-diagnose ka na high blood before 20 weeks AOGC, 17 weeks, okay? Na-diagnose ka na high blood ka, nag-150/100 ka. Chronic hypertension tawag doon. Kasi hindi mo siya masisisi sa placenta. The placenta is not mature enough or it's not producing enough hormones for it to be the culprit behind the pregnancy-induced hypertension. In the same way, kaya siya nagpo-persist after 12 weeks kasi beyond 12 weeks, hindi mo na yan masisisi sa placenta. Okay? Hindi mo na siya pwedeng sisihin na, high blood ako kasi pre-eclampsia ako eh. Tapos 6 months na postpartum. High blood ka na talaga, ma'am. Yun lang po talaga yun. Okay? We have to accept that. Ayan. Inulit ko lang pala siya dito. Okay. Hindi pala. Sabi ko dito, prior to pregnancy, this is first diagnosed after 20 weeks, pero persistent after 12 weeks. So magkaiba yun, no? Pwede naman na on monitoring, pwede namang na-diagnose ako 24 weeks, pero upon monitoring, beyond 12 weeks, I'm still high blood. I'm probably really chronically hypertensive already. So meron din tayong chronic hypertension with superimposed preeclampsia. So hypertensive na nga ako baseline, meron pa akong preeclampsia. So what's at fault here is my lifestyle disease or my baseline hypertension. On top of that, pati yung placenta ko is making my BP so high. So ano ba yung qualifications mo for this? New onset or worsening baseline hypertension accompanied by new onset proteinuria. That's why if you have a chronic hypertensive patient, important na meron kang baseline 24-hour urine collection. Okay? Kasi we take note of that in your as you progress in your gestational age. Or if there are other findings of end organ dysfunction that is not present prior to pregnancy. So these are the qualifications for you to be labeled as a patient with chronic hypertension with superimposed preeclampsia. Doktora, pwede po bang chronic hypertension with superimposed preeclampsia without severe features? Pwede. Meron ding chronic hypertension with superimposed preeclampsia at malas ka with severe features ka pa. Pwede din yon. So hindi porque you have superimposed preeclampsia, you're already labeled as with severe features. Kailangan hanapin mo pa rin ito. Yung severe features na to or the BP criterion of greater than or equal to 160/110. Malinaw? So hindi porque chronic hypertensive with superimposed preeclampsia, nag-magnesium sulfate na ha, hindi siya automatic. Okay. So what's important about yung mga management, yung nitty-gritty nun, sige, I'll leave that up to you. You have to read the CPG. We have a very good CPG for hypertension in pregnancy. For this one, I want to impart with you, importante to, timing of delivery. So as I mentioned, importante na ma-deliver yung placenta. Pero hindi naman pwede, di ba, anytime lang kasi you have two patients here. So you have to balance the good of the baby versus the mother kung meron na siyang presence ng end organ damage. So dalawang binabalance mo dito. This is a balancing act. Siyempre, hindi ka pwedeng mag-deliver ng 2 preterm a baby. Hindi ka rin naman pwedeng magpatagal ng mother just because you want to keep the baby, to mature the baby longer. So for gestational hypertension and preeclampsia without severe features, pagpatak niya ng term, meaning pagpatak niya ng 37 weeks, you already have the right to induce labor. Okay? I-admit mo na yan for delivery. So wag kayong magtataka kung i-admit kami, GH, gestational hypertension lang, di naman nagli-labor. Ano ba yun? Pinapabantay pa ako ni Doktora. We have to deliver these patients at 37 weeks to avoid incurring further end organ damage to the mother. Kasi pwede yung mag-progress to preeclampsia. However, in the presence of severe features, 34 weeks, whether you have preeclampsia with severe features or whether you have preeclampsia at chronic hypertension with superimposed preeclampsia, basta may severe features, may karapatan ka nang mag-deliver at 34 weeks. So ito yung consensus namin na age of gestation na it's relatively safe to deliver a preterm baby, and at the same time, ito yung perfect timing din para hindi naman mag-progress to having end organ damage yung mother. Now, eclampsia regardless of the AOG of the mother, since nag-seizures na, ito yung pinakaayaw nating ma-reach na point for the mother, we deliver. Okay? Regardless of AOG. Ito, important to, chronic hypertension na uncomplicated siya. So, hindi mo masisisi ang high blood sa placenta. So, if you determine your patient to have just hypertension, then you can prolong the pregnancy up to 38 weeks. Doktora, bakit mas matagal pag chronic hypertension? Eh, ang tagal na nga niyang high blood. Exactly. This is because sanay na yung body ng mother na kapag adapt na siya to an environment of high BP. Okay? A hypertensive environment. So, pwede ka pang maghintay. So, well-adapted na siya doon. Pero kapag chronic hypertensive with superimposed preeclampsia, basta preeclampsia, gestational hypertension, that's pregnancy-induced, that's because of your placenta, deliver at 37 weeks. Malinaw? Basta may severe features, guys, ha? 34 weeks. Yung medyo papatagalin mo lang na pwede mong patagalin ng konti. Chronic hypertension na uncomplicated. Well-controlled BP, walang superimposed preeclampsia, walang severe features yan. Pwede yung tumagal, 38 weeks. Beyond that, baka ma-judge tayo kapag hindi tayo nag-admit and induce ng patients. Okay? Na high blood. Okay. So next part of your P is your fundal height or your fundic height. So around 20 weeks to 34 weeks AOG, kung ano yung fundic height mo, that roughly correlates in centimeters to your gestational age. Meaning, kapag 20 weeks yung baby ko, around 20 centimeters yung fundic height ko. So this is measured along the abdominal wall from the top of the symphysis pubis. So may bony, doon sa bony pelvis, I will show you later on a picture, to the top of the fundus. That is your fundic height. So prior to measuring your fundic height, you must ask the mother na, Mommy, ihi ka muna. So bakit to important? Una sa lahat, we will be pressing on the symphysis pubis. So, baka maihi siya kapag nag-start ka doon ng measuring tape. Second, pwede niyang mag-increase yung fundic height mo. If your bladder is not completely empty, so paihiin niyo muna sila. Prior to taking your fundic height, pahigain niyo sila sa spine on your examination table, like so. So, this is how you take your fundic height. So, there is a bony part there sa anong nyo, sa above your mons pubis. And you look for the tallest point of your fundus. That is your fundic height. So 20 to 34 weeks, important din yan manote. Mamaya may question ako regarding that. Bakit important yun i-note? Kailangan sa ulo niyo siya. 20 to 34 weeks, your fundic height or your fundal height in centimeters roughly correlates with the gestational age. Okay, so doktora, ito pa, actually isa pa tong way to note the gestational age kapag hindi talaga niya alam. Pero nakapang mo yung height ng fundic height sa may umbilicus. Meaning, around 20 weeks AOG yung patient. So, you know na kapag 12 weeks, beyond 12 weeks, nagiging abdominal organ na siya above the pelvic brim, umaangat na yung uterus mo. So, pag sinabi mong 12 weeks corpus size, ibig sabihin, nakakapa na siya beyond the symphysis pubis. So this is just an estimation, you guys. So more of clinical eye and clinical PE talaga. Sin correlate talaga to, guys. Pero ito, ang pinaka-importante siguro, si 20 weeks. Kasi siya yung pinaka-notable na anatomic landmark. Kapag nakakapa mo na yung fundus mo sa level ng umbilicus, your corpus size, your AOG, is around 20 weeks. So between the symphysis pubis and your umbilicus, 16 weeks. So the rest, ayan, ipupundik height ko na yan beyond the umbilicus. Okay? So maganda din siya. Actually, yung corpus size, minsan ginagamit din namin siya, hindi minsan, ginagamit talaga namin siya pang-describe ng size ng matre. So if you have myoma uteri, you are free to label your corpus na or your uterus that is enlarged to 20 weeks. So pag ganun, gets na namin, hanggang sa fundus yung uterus ng patient. Okay? Na-gets nyo, guys? So importante din to. Importante siya later on pag nag-ask ako ng questions regarding this. Okay, so give for instances when your fundic height is greater than your AOG at 20 to 34 weeks. So una, you could be dealing with a large baby, macrosomic baby. Sometimes tandem yan. Most of the time, tandem to pag diabetic yung baby mo. bukod sa macrosomic, pwedeng marami siyang water or marami siyang amniotic fluid or polyhydramnios. So, tandem siya sa gestational diabetes mellitus because, di ba, pag diabetic baby, they have a tendency, pag diabetic yung mother, you have a tendency to have central obesity or truncal obesity in your babies. May, tawag nan, disposition, not disposition, may, basta na sa store, sa truncal area, yung fats. So you have a macrosomic baby, you have a big baby greater than the 90th percentile for that gestational age. At the same time, para kang may, di ba, ang mga diabetic adults, they tend to have polyuria. Ganun din sa babies. So the more na umiihi yung baby, the more na dumadami ang amniotic fluid because your amniotic fluid is mostly composed of your urine, your fetal urine, beyond the second trimester to the third trimester. So usually combo yan. So ito yung una mong iisipin. Baka yung baby or sobrang daming tubig, kaya mas malaki yung fundic height mo ng dihamak compared with your gestational age. Next, ano pang iisipin mo pag sobrang laki ng fundic height mo compared with your AOG? You could be dealing with a multifetal gestation. Baka hindi lang isa yung baby mo, hindi lang yan singleton. Baka may twins ka, di ba? Second, you could be dealing with smaller pregnancy. So isa to sa mga pertinent PE, isa to sa mga iisipin mo kapag sobrang laki ng corpus size niya, ng fundic height niya compared with the computed AOG that you have. Ano pa? Siyempre, kapag may myoma yung patient, kapag mayroon siyang ovarian new growth that you could mistake for the fundus, pwede mo siyang makapa as increased fundic height. So this is the fourth instance na naiisip natin kapag mayroon kang fundic height that is greater than your AOG. In the same light, going back to the macrosomic baby, kapag ang fundic height mo naman is more than 3 centimeters na less than your AOG, so yung kabaliktaran naman yung isipin mo. You may be having a very small baby. Pwedeng SGA yan paglabas or dahil meron siyang intrauterine growth restriction. So let's go to this next question. So you have an 18-year-old preemie-gravid, 32 weeks AOG. She has pre-eclampsia with severe features. Note na she is a young preemie-gravid. So isa yan ang dalawa ang kanyang risk factor dito. She's young preemie-gravid. Second, she's preemie-gravid. So it's her first time to be exposed to your placental tissues. So that's the immunogenic theory behind placenta, behind pre-eclampsia. So if it's your first time to be exposed, you're preemie-gravid, you're more likely to have pre-eclampsia with severe features. Okay, so ang importante dito sa question stem na to is that 32 weeks na siya, pero tingnan nyo naman yung fundic height, 28. Remember, di ba, ang 20 to 34 weeks dapat nagpo-correlate si fundic height and AOG. So what you are dealing with here is a probable case of intrauterine growth restriction. Okay? So hindi siya lumalaki na baby. So anong risk factor nito ni patient? Meron siyang pre-eclampsia. So hindi maganda yung uteroplacental unit niya. She could be having uteroplacental insufficiency secondary to her high blood kasi instead na vasodilated, vasoconstricted yung kanyang vessels in her placenta. So, hindi nag-grow ng tama si baby. Okay. So, as I mentioned, yung fundic height is correlating well with your AOG around this time. So, alin dito yung expected findings mo sa IUGR? So, isa-isahin natin from the bottom. Okay, her estimated fetal weight is less than the 10th percentile. So, that is consistent with your IUGR. Abnormal Doppler findings. Your Doppler findings, guys, nagpapa-Dopplers tayo if we are wary of uteroplacental insufficiency. So, warranted kay patient, diba? Because she has hypertension. So, kailan ka pang magda-Doppler? Other instances na pwede kang may uteroplacental insufficiency, pwedeng diabetic mother, pwedeng meron siyang APAS, okay? So any disease or comorbid condition si mother that would predispose her to having uteroplacental insufficiency, that's it, okay? Magpapa-Dopplers tayo kasi hindi to left and right ginagawa. For a normal pregnancy, we don't order Dopplers. So abnormal Doppler findings, okay, that's consistent with your intrauterine growth restriction, especially in the background of preeclampsia. No increase in estimated fetal weight after 2 weeks. Yes, okay, that is also consistent with your IUGR. Second, yung first, abdominal circumference is larger than the head. So, meron kasi tayong tinatawag, guys, na brain sparing. Kapag may intrauterine growth restriction ka, or actually in the presence of an injury to the baby, like in the cases of your uteroplacental insufficiency, there is what you call brain sparing, meaning the body, the fetal circulation in particular, prioritizes the circulation to the brain. Kaya siya brain sparing. You spare the brain from hypoxic injury. So dapat, ang mas malaki is the head circumference compared with the abdominal circumference. Na-get? Okay? So dapat, kung may IUGR ka, yung head yung mas malaki than your abdominal circumference. So the correct answer here is letter A. Okay? Na-get? Okay, so next, this is one important maneuver for us, your Lupol's maneuvers. So important to for us because this tells us the lie of the baby, whether transverse or longitudinal or oblique, and also this tells us the presentation as well as it aids us in terms of determining where to find the fetal heart tones. Okay, where to find the fetal heart tones and to engage yung baby natin. So that's how important your Lupol's maneuvers are. So usually when we report this, L1, L2, L3, L4, because you have 4 Lupol's maneuvers. So si L1, we start by palpating the fundus. So si L1, ang dinedetermine niya kung anong fetal parts ang nasa fundus. If you palpate a large nodular mass, that means that the fetal breach is at the fundal part, okay, at the fundus. Meaning, ang nasa baba mo is your head. Cephalic yung presentation mo kung yung breach yung nakakapa mo dito. Pero kapag ang nakakapa mo sa L1 is a hard, round, mobile, ballotable mass, it means na yung fetal head yung nasa fundus. Doktora, ngayon ko lang narinig yung ballotable. Ano po yung ballotable? Okay, ballotable means that when you press it down, it will bounce back up. Okay? Yun ang ballotable. So, mafe-feel mo yan. Kapag ulo yan, kapag puwet kasi yan, hindi yan ballotable. But if it's your head, it's ballotable. Ano pong significance ng doktor? Ano yung ballotable? So anyway, kaya nagiging ballotable, guys, because your head has your cerebrospinal fluid, your CSF. That's why it is ballotable on your L1 or on your Lupol's maneuver 1. Okay, so your next Lupol's maneuver is your L2. So kung papansinin niyo yung kamay, yung hand, yung palm, ay nasa side ng mother. So there are different ways of doing it. Sabay ko siyang ginagawa. But others, they would teach you na kapag when you do your L2, yung isang hand stationary, tapos yung isa, ikakapa niya yung other side, yung contralateral side. And then you do the same. So ito naman yung stationary, yung isa naman yung kakapa. Pag nagmamadali kayo sa ER, sinasabay ko na siya, guys. Ang important lang kasi talaga dito is you will know kung nasaan yung hard resistant structure that is convex. So yun yung important. Alam mo na fetal back yan. Ito, this is very, pag nakapag-Lupol's maneuver 2 kayo, it's very telling. Okay? It's very telling. Kasi yung iba minsan malilito ka sa fetal parts, immovable parts. In fact, hindi ko to ganun ka na-appreciate. But yung fetal back, ma-appreciate nyo talaga siya. If your patient is not that obese, kapag advanced in AOG, maganda siyang gawin, no? Maganda siyang i-note. Also, what your L2 will help you determine also is the fetal lie. So the fetal lie is kung yung axis ng baby, no? Kasi pwede siyang transverse. Pwede din siyang longitudinal. Pwede rin siyang oblique. Although very rare ang oblique. So ano po bang importance kung nakapahalang, naka-transverse si baby or naka-longitudinal? If transverse, guys, tapos term na yung patient, kung malaki enough yung baby mo, hindi siya ganun kaliit, and it's transverse, CS yan agad. Okay? Magmamatter kung ano yung position niya, later na yung position pag nandun na tayo sa labor part. But for now, what's important for you to understand is kapag ang kapa mo sa L2 ay yung transverse lie, cesarean section yan. Okay? Sige. Now we move on to L3. They also call this pollex grip. So, for L1, L2 guys, ang position ng examiner is you are facing the maternal head. Okay? So, si L3, this is performed by grasping with the thumb and the fingers, one hand, the lower portion of the maternal abdomen above the symphysis pubis. So, aside from confirming kung ano yung presenting part, this also tells you if the head of the baby is engaged or not. Anong ibig sabihin ng engagement? Okay, ang engagement, guys, is if your BPD, your biparietal diameter, is already past the pelvic brim. Okay? So, pag past na siya ng pelvic brim, engaged na siya, hindi na siya mobile. Hindi mo na siya ganun ka magagalaw. But if it's still floating, mataas pa, doon mo siya ma-determine sa pollex grip sa L3. Okay, L4, so kung yung L1 to L3, nakaharap ka kay mother, when you do your L4, you have to reverse your position. You will now face the mother's feet. So you do this by using your 3 fingers of each hand, and then you exert deep pressure in the direction of the axis of your pelvis, of your inlet. Okay, so this determines the degree of descent, and at the same time, this also tells you if the patient, what the fetal attitude of the baby is. Okay, explain ko yung fetal attitude na yan. So, degree of descent, syempre, kapag halimbawa, mas mababa na siya, nag-engage na siya, nasa loob na siya ng pelvic brim, hindi mo na mapapag-meet yung dalawa mong fingers. So, one more thing that you have to note on L4 is your cephalic prominence. Okay, so your cephalic prominence, kapag nasa same side siya ng maternal back mo, it means that your head is extended. Okay? Na-imagine nyo ba? So if your cephalic prominence is nasa same maternal side siya as your convex hard structure or your fetal back, then ibig sabihin, naka-extend yung head mo. However, kapag fully flex yung baby, nasa same side siya as your irregular part on L2. Na-get? So, important din siya kasi, syempre, ang gusto natin, naka-flex yung baby when you descend into the pelvis para makapag-vaginal delivery tayo. Later on, I will also discuss that in the cardinal movements of labor. Okay, so that's your L1 to L4. I hope that's clear. So, I have a question for you guys. So, you have a multigravid patient, 31 weeks, so magandang time to do your Lupol's maneuvers. So occupying the fundus is a nodular mass with a hard convex structure on the maternal right. So nasa fundus, nodular mass. So breech yung nasa fundus mo. Hard convex structure on the maternal right. By the way, guys, when we see right, obvious na yan na maternal right. So minsan pag nagda-drive ako dyan, minsan nalilito ako sa directions kasi I turn left sa right because the maternal right is this one, maternal left. Okay, yun na yung orientation. Okay, yun na yung orientation minsan ng utak ko. So when you see right, obvious maternal right, that's what you always refer to. So yung convex structure na hard, meaning your fetal back is on this side, maternal right. And on suprapubic palpation, there is a round ballota ball mass, so cephalic yung nandito. So yung L3 mo, it confirms your L4. So sa ang quadrant ka, likely makakarinig ng heart tones. So likely mas makakarinig ka dito sa right lower quadrant where your head is. Siyempre kapag nasa taas yung ano mo, kapag breach yung presentation mo or cephalic yung nakapa mo on L1, siyempre nasa upper quadrant yung heart tones mo. And then kung nasaan yung fetal back, dun ka mas makakarinig ng fetal heart tones. Okay, so ito, right lower quadrant, based on the Lupol's maneuvers results or findings that were described in the question. Nag-get? Okay. let's move on. So since I already mentioned it, so another important part of your physical examination is your fetal heart tone. So speaking of fetal heart tone, kailan mo siya unang manonote? So the earliest that you can note this is on transvaginal ultrasound at 6 weeks. So makikita mo yan, cardiac motion. There is flickering already on ultrasound in your 6 weeks EOG patient. Pag Doppler ultrasound, anong Doppler to, Doktora? Doppler na ultrasound? Hindi guys. Doppler as in yung Doppler na nakikita nyo sa clinics namin, yung mabibili nyo sa Shopee, that Doppler. At 10 weeks, if you have a good Doppler ultrasound, naririnig mo na yung FHT. At 20 weeks, using your standard non-amplified stethoscope, meaning kung ano lang yung meron kayo, yung cardiac stethoscope, most of you will already hear the FHT. Especially when you use the bell. Okay? Mas gusto natin yung bell rather than the flat or the diaphragm of your stethoscope. Mas maririnig nyo yung heart tones with that. Pero in all women, pag 22 weeks, dapat maririnig mo na siya. So hindi pwedeng excuse ng interns. Doktora, yung pangit kasi yung ano ko eh. Pangit po yung stethoscope ko. Pero, tapos yung patient mo ay 24 weeks na, 28 weeks na. Hindi, maririnig mo yan dapat. Okay? You just have to look further, baka naka-close yung bell mo when you're auscultating. So, 22 weeks, dapat sa lahat makakapag FHT monitoring na kayo using your own stethoscope. Okay, so now let's move on to the sonographic findings of pregnancy. So, ang first na evidence mo ng pregnancy is your gestational sac. So, this is a drawing, this is a representation of your gestational sac that is implanted inside the uterus. So, ang description niya sa gestational sac, so it's this one, it's an anechoic na regular siya, na mukha siyang cyst, diba? When you see kasi echoes, guys, pag ultrasound, we describe it in terms of echoes. Pag anechoic, meaning walang nagre-reflect back ng sound. So, black lang siya. So, ito siya, anechoic. Kapag white, ang description namin doon, hyper-echoic. So, maraming nagre-reflect back ng echoes. Okay, kapag medyo grayish naman siya, hypoechoic siya. Okay, so ito, anechoic cyst siya na eccentrically placed. Ano yung sabihin na eccentrically placed na gestational sac na structure? When you see eccentrically placed, it means wala siya sa midline. Because as you can see, your gestational sac, it implants either on the anterior, posterior, basta hindi kasi sa gitna. Okay? Why is it important to note? Kasi merong tinatawag na pseudo-gestational sac. By the way, guys, yung gestational sac, as early as 4 to 5 weeks, you can already note that on your ultrasound. That's why it's the first sonographic evidence of pregnancy. Meron kasing nakakalitong image. So this is your pseudo-gestational sac. Kung papansinin nyo, no, irregular siya, hindi siya bilog na bilog, and it's right in the midline. So when you have this, it means na may fluid collection ka sa gitna ng uterus mo. So hindi siya nag-implant anywhere. So where do you see your pseudo-gestational sac? This is one of your typical findings of in ectopic pregnancy. Okay? Na-get? So ito binhi. So gestational sac, this is a good sign for you. But when you see this, you can't label this as gestational sac. So una sa lahat, irregularly shaped siya and then gitnang-gitna siya. So pseudo-gestational sac siya. So the next finding that you will find, so based on God's design, we are given the structure first before we come to form. Okay? So yolk sac. Yolk sac becomes the temporary form of source of nutrition of your future embryo. So ito siya, guys. It's a regularly shaped na circular structure inside your gestational sac. So dyan manggagaling yung source of nutrition. So anechoic din yung kanyang inside and meron siyang hyperechoic din. So that's your yolk sac seen between 5 to 6 weeks or 5.5 weeks. So after your yolk sac, saka ma-form si embryo. So as you can see, ito si yolk sac, which is the source of nutrition. And then this is your embryo. So that's your embryonic plate. So this will eventually become the fetus and the baby. Okay? So ito siya. So at 6 weeks, dapat may cardiac motion ka na, may flickering ka na manunod on transvaginal ultrasound. So one note again about ultrasound. So kailan kami nag-transvaginal ultrasound, kailan pelvic ultrasound or transabdominal ultrasound. So 12 weeks and below, since nasa loob pa siya ng pelvic brim, di pa siya abdominal organ, transvaginal pa yan. But beyond 12 weeks, doon na kami nag-transabdominal scan. Okay, na-get? Let's move on. Now, this is another unique physical examination that we do as OBGYN. We perform internal examination and speculum examination. So the way we describe it is from labas paloob. Okay, so we start with the external genitalia. So kung wala namang anything abnormal, normal external genitalia. And then when you insert your speculum into the vagina, you will note that there are no masses, so smooth, porous vagina. Okay, going back to the cervix. As I mentioned, marami tayong ways to describe the cervix, lalo na pag buntis. Okay, so sa buntis lang to guys ha. Actually, this mnemonic, this is my mnemonic for your bishop score. These are your components of the bishop score. But basically, pag nag-IE ka, ito rin naman yung hahanapin sa inyo. So I will be teaching you this mnemonic already. So isipin nyo na lang, when you're pregnant, you have to call PEDS. You have a pregnant patient, call PEDS or pediatrics. So C stands for consistency, P is for position, E is for your effacement, D is dilation, it's the same as dilatation, station is your last component in your bishop scoring. Okay, so ito yung ito yung most complete way of describing cervix for us, OB-wise. So isa-isahin natin yung isa. When you see consistency, it's the texture of the cervix on examination. Again, this is subjective, guys. Firm, medium, soft. Tatlo lang naman siya. So if it feels mushy already, then that's soft. So isang hindi ko makakalimutan na sinabi ng resident in charge ko when I was clerk. Sabi niya, ito daw yung firm, ito yung medium, the tip of your nose, and then your lips, that's soft. Okay, so that's for your consistency. I never saw that in any book. I never heard it from anyone else, but that's siguro one good way or parang one subjective way of describing it to someone who will be doing IE for the first time. Okay? Next is your position, diba? Sa call P. So P, tibia. So your position, you can describe it as anterior, mid-position, posterior. So ano yung dinidescribe niya? So in dinidescribe niya is the position of the cervix against your presenting part. So if it's more towards the symphysis pubis, this is your mons, the symphysis pubis, the part, the bony pelvis on the area of your, near the area of your mons, that's anterior. Pag doon mo nakapa yung cervix. Pag mas close naman siya to your sacrum, then posterior siya. Okay? So na-imagine nyo ba, if this is the head, the presenting part of your baby, and your cervix is anywhere along this axis, that is how you will describe the position of the cervix in relation to your presenting part, usually your head. So the next component in your IE is your effacement. So effacement is how thin out your cervix is. So kapag uneffaced siya, it's around 2.5 to 3 centimeters long, mahaba. Yung sinasabi naming makapal. Makapal pa, Doc, yung cervix niya. Pag sinabi naming manipis na yung cervix niya, it's going towards the fully effaced spectrum of description. Pag sinabi mong fully effaced, 3% na yung cervix mo. Okay? So kung gaano ka-thinned out yung cervical length mo, so mas numinipis siya. Na-imagine nyo ba? It's hard to describe, pero usually, ang ginagawa ko, I use as a reference this, my index finger. So this is around mga 2.5. So kapag yung length ng endocervical canal mo is as long as your index finger, makapal pa po, doktora, yung cervix. Okay, so half of this, 50% effaced. Okay, tapos kapag sobrang nipis na fully effaced. Okay, don't quote me on that one. Okay, sa totoo lang guys, ang internal examination is a very subjective examination. But across all OBGYN sa mga pag-duty ko, and even my more senior or even my more junior obstetrician friends, parang pare-parehas naman kami ng IE or nagkakaintindihan kami at least ng IE, even though it's a very subjective examination, no? So yun yung ano ko. That's how I take note of effacement, okay? But basically, uneffaced means makapal pa siya, mahaba pa yung endocervical canal mo. Pag fully effaced na siya, your presenting part has already thinned out, like this one. It has already thinned out your cervix to the point na halos paper thin na yung edges ng cervix mo, okay? So next, colpeds. Next is dilatation. So siguro ito yung pinaka-popular, no, na description ng cervix. So 1 centimeter, 2 centimeters, 3 centimeters, 5 centimeters, lahat yan estimation lang, guys. So kapag nakapasok yung 2 finger breadths at around 2 centimeters, isa lang yung napapasok mo, 1 centimeter. Pag hindi mo siya napapasok yung fingertips mo, it's closed. Okay? Ang fully dilated, ulo na lang yung nakakapa mo. Wala ka nang nakakapang cervical rib. Ulo na lang. So, it's a bagel. Okay? So, in terms of food, ito yung food guide to cervical dilatation. But essentially, without memorizing this, ang full cervical dilatation kapag wala ka ng ibang nakakapa but the presenting part, the patient is already fully dilated. Okay? So, sige. So, ito yung, as I mentioned, ito yung parang, ilang cms na yung patient mo? 2 centimeters, doktora. Just take note, guys, na ang tinitingnan namin dito is the dilatation of your internal os. Remember your cervix? If you can see this, no? Ito yung cervix mo na uneffaced. Dalawa ang opening niya. External os and your internal os. Itong opening na to, itong dilatation nito, yun ang dinidescribe namin rather than the external os. Why? Because if you have a multiparous patient, minsan bukas na bukas to, guys. So magkakamali ka minsan ng i-describe. Ang i-describe mo talaga, yung ito, yung internal os. The one that is nearer to your presenting part or to the fetal head. Okay? So yun yung i-describe natin. How open this opening is, this internal os is. Next, speed. So next is your station. So station is describing to you the level of the descent of the head, okay, or the the lowest presenting part, the most dependent presenting part. So when your anatomic landmark for this is your ischial spine. So when you do your pelvimetry, may makakapakang parang patusok sa along the vaginal walls. That's your ischial spine, and that's a marker. That's a very important anatomic marker or landmark. So pag nandyan na yung presenting part mo, the patient is at station 0. The head is at station 0. That's how we describe it. So anything above your ischial spine, so above meaning mas paloob, mas pataas, okay? So ito yung umbilicus mo. Anything towards the umbilicus, pataas, negative. Negative 1, negative 2, negative 3. Pag mas mababa sa ischial spine, positive. So 0, 2, 2, 2, 4, plus 4. So pag crowning na yan, plus 4, plus 5 na yan. Okay? Call your resident or ikaw na magpaanak niyan. Alright? So another important point why we have to note where the ischial spines are, dyan din yung marker namin for the pudendal block. Okay? Yung ischial spines mo. What else regarding the ischial spines? So as you notice, dito sa pelvic cavity niya, after the, okay, siguro, before it reaches the outlet, ito yung area with least dimension, okay? So kung papansin niyo, medyo wide open yung pelvic brim, pero ito, dito siya, ito yung pinakamakipot niyang dadaanan. So later on, when I describe the cardinal movements to you, makikita niyo bakit kailangan mag-rotate yung ulo to the anterior or posterior at the level of the ischial spines. Alright? Sige. We'll go back to that later on. Now we'll go to the labs and medications or others. So yung medications, hindi ko masyado itong tinouch on, but the labs, sige. I will touch on this. So ito ang mga kailangan nyong i-request for the patient. So we're done with the history, we're done with the PE. Ngayon, utusan ka na ng resident, okay, order labs for the patient. Okay, so ito, pag first visit niya, these are the laboratory na typically in-order natin locally. So CBC to check for anemia, blood typing. Bakit important yung blood typing, guys? Bukod sa pwede kasing mag-transfuse during pregnancy or during labor even. Bukod doon, you have to check for the presence of your RH. Okay? Kailangan important sa amin kung RH negative or RH positive yung mother. It matters to us kasi magbibigay kami ng immunoglobulin kapag RH negative. So most of Filipinos naman RH positive. Yun yung O positive, AB positive, B positive. But we have in rare patients, we have RH negative patients. So later on, I will explain why this is significant for us. And then we do pap smear. So ba't ka nagpa-pap smear ng buntis? This is opportunistic screening for cervical cancer. Yun lang talaga siya. Okay? SBS, we do this during the first visit. Paano kung ang first visit niya, doktora, 24 to 28 weeks, you go straight to your 75-gram OGTT. Okay? Doon tayo sa 75-gram OGTT. Mamaya explain ko to further, bakit 24 to 28 weeks. Next is urine culture. We don't order urinalysis. The preferred is urine culture. Pero since this is expensive, some OB opt to perform urinalysis. But it should be urine culture. That's what's in the book. Next is your hepatitis B infection screening test, which is your HBsAg. Next is rubella antibody screening. So if you have protection against rubella. Next is you have to screen for syphilis. So you can do this by requesting RTR or VDRL. At HIV serology, we offer this. May opt-out option kasi for HIV. And then your GBS culture, we swab the rectovaginal, we do rectovaginal swab or RDS, sorry, redundant, at 35 to 37 weeks, okay? This matters kasi pag ito nag-positive, we give prophylaxis against your GBS, okay? Or your group B streptococcus. All right. So other than your laboratory test, so these are the things that, these are the imaging that we order. Transvaginal ultrasound within the first 12 weeks. After that, biometry. Biometry, mini-measure mo si baby. Thereafter, you can add your biophysical profiling. I will discuss this in detail later on at 28 weeks. So pagpapunta ka na ng third trimester, we already include this BPP. So next, Doppler studies. As I mentioned a while ago, kapag may comorbid condition si mother, if there is any predisposition for her to have uteroplacental insufficiency, we check the Doppler studies of the placenta and the arteries, okay? Congenital anomaly scan, this is as needed. So itong naka-asterisk na to, as indicated lang siya. So when do you do congenital anomaly scan? So there are multiple instances. For example, you have a previous baby with a congenital disorder. So you do that. Second, probably kapag nakapag alcohol intake during the first trimester, okay, we do CAS also or targeted anomaly scan. Next, for example, 35 years old. Okay, so that's also one reason why we tag elderly preemie-gravid. Okay, or actually kahit hindi preemie-gravid, basta 35 years old and above, we offer congenital anomaly scan. Doktora, pag wala naman ng mga risk factors, ganyan, walang family history, wala naman pong intake ng any teratogenic medications, pwede bang magpa-congenital anomaly scan? Pwede naman po. But this is relatively expensive and we usually do this 18 to 20 weeks. So may window period. Pwede pa rin gawin beyond 18 to 20 weeks, pero we offer the patient and we tell them kung gusto nila, timingan nila ng maayos at 18 to 20 weeks. Alright? Sige. Kasi mahaba, mas mabusising examination kasi to ng for your baby. Okay, so this is what I am mentioning when I say that we have to do blood typing. Because you can have RH incompatibility. Ngayon, may dalawang kinds of incompatibility, alloimmunization from na based sa blood typing. ABO incompatibility, this is more common pero this is less severe. So this happens when the mother is O, yung blood type niya, and the baby is A or B. So no desensitization needed. So yung baby, first baby pwedeng ma-affect. Mamaya sasabihin ko sa inyo kung ano yung sensitization na tinatawag. So since hindi naman kailangan ng sensitization for your ABON compatibility, pwede ma-affect si first baby. So yung babies na to, they can present with mild anemia. To be honest, guys, itong EBO incompatibility, hindi na to nare-refer sa amin. More of yung pedia, yung mga na-manage ng cases of
incompatibility.
So, ano yung mas pertinent sa aming mga OB? It's the RH incompatibility. So, if you have an RH negative mother with an RH positive baby, your baby could have severe anemia from the RH incompatibility. So, there will be alloimmunization. It means that the mother's body will fight off the RH positive blood type of your baby. Okay? So sensitization is needed for this. So meaning, kapag na-expose sa RH antigen yung mother the first time, mapapalampas pa yan. Okay? The first baby is safe. This is for the G1. But for the succeeding babies, your mother will already have antibodies against the RH antigen. So, kapag nagkaroon ulit siya ng second baby na RH positive, the mother there could be an alloimmunization between the mother's blood and the baby's blood pag naghalo yon. So this will result to anemia in the baby. So this is more severe, okay? Fortunately for us, among Filipinos, this is not as common, the RH negative mothers. So, okay, so ito yung sinasabi ko, guys, na RH incompatibility and alloimmunization. Sa first pregnancy mo, si baby, di ba, meron siyang RH antigen. The baby is positive. Si mother, since wala RH negative siya, she will form antibodies against the RH antigen of the baby. So pag first baby, pag kapag halimbawa siya ay na-deliver and na-expose, there's mixing of the maternal and the fetal blood, that's when the mother will form antibodies. Okay, so lalabas ng walang problema yung first baby mo. However, in the next pregnancy, kapag nagkaroon ulit ng mixing ng blood either during labor, during times of obstetric hemorrhage or preterm labor, kapag halimbawa nagkaroon ng mixing ng blood between the baby and the mother, the antibodies of the mother that were formed during the first pregnancy will fight off the RBCs of your baby. That's why the second baby of those RH negative mothers with babies na RH positive for their G2, yan, dyan na nagmamanifest yung RH incompatibility.